working with Takeda. And so we have a big trial group, so I'm presenting on behalf of the TIDES study group. So these are our acknowledgements. So there are many people who are supporting this trial globally. Particularly, I would like to thank the contribution of the trial participants, their families, and also the investigators of this trial. So I'll be reviewing the study objectives, endpoints, and also give you a brief introduction to the study design, and then I'll present the results. The primary endpoint of this trial was overall vaccine efficacy, and the secondary endpoints were the subgroup analysis of vaccine efficacy, which is vaccine efficacy by serotype, serostatus against hospitalized dengue and severe dengue. This slide shows the study design. We enrolled 20,099 children in the age of 4 to 16 years. 2/3 received vaccine, 1/3 received placebo. The dosing schedule was 0 and 3 months. You can see in this slide. A month after the second dose, we started counting cases for endpoint evaluation. Every participant was sampled at baseline for baseline serostatus assessment. Primary endpoint, which is the overall vaccine efficacy, was assessed in the first year after the second dose. And the secondary endpoints, which are the subgroup analysis, so those were assessed in the first 1.5 years after the second dose. So we have an active form of surveillance, which continues for the duration of the trial. So we detect both hospitalized and non-hospitalized cases, and cases are confirmed through PCR evaluation in a central laboratory. You can see in this slide, both the groups were comparable in terms of baseline characteristics. In the trial population, 28% were seronegative to all 4 serotypes, and that is our seronegative definition. Mean age was 9.6 years at enrollment, and the enrollment is similar in proportion in Asia and Latin America. We detected 210 cases for primary endpoint evaluation, which is the overall vaccine efficacy. On the right side, you can see a higher proportion of the cases were detected from Asia, where we saw all 4 serotypes, relatively fewer serotype 4. And in Latin America, we saw primarily serotype 1 and few serotype 2 cases. Our overall vaccine efficacy in primary endpoint evaluation was 80%. If we also consider from first dose onwards, and in the safety set, we also have a similar vaccine efficacy of 81%. There was additional 6 months of follow-up before we assess the secondary endpoints, which are the subgroup analysis. During this 6 months period, we detected 111 additional cases. Half of those cases were serotype 1, a third were due to serotype 3, and a fifth were due to serotype 2. We detected only 3 more cases of serotype 4 during this period. So altogether, for secondary endpoint evaluation, we had 321 cases of dengue. So efficacy varied by serotype. We have a 70% efficacy against serotype 1, 95% efficacy against serotype 2, and in the range of 50% for serotype 3 and 4. To point out, for serotype 4, it wasn't statistically conclusive. Overall, in the secondary endpoint assessment time frame, we have a 73% efficacy. Now, efficacy by baseline serostatus, we have 66% efficacy in baseline seronegatives versus 76% efficacy in baseline seropositives. Hospitalized dengue was our key secondary endpoint, and we have 90% efficacy against hospitalized dengue. If we consider from first dose onwards to end of part 2 in the 21 months time frame, we also have a similar vaccine efficacy. We assessed severity using two approaches. One was based on the WHO 2009 severe dengue criteria. This was defined by our data monitoring committee, and they focused the presence of functional impairment or requirement of significant interventions. Using that, we had 3 cases, all due to serotype 3, and we did not demonstrate efficacy there. Using the other approach, that's the WHO 1997 dengue hemorrhagic fever criteria, we had 9 cases contributed by 3 serotypes, and we have 86% efficacy there, and we met that endpoint. So this slide shows the cumulative incidence of dengue cases, which are PCR confirmed, both hospitalized and non-hospitalized. The upper 2 lines are the placebo curves. The below 2 lines are the vaccine curves. Blue is seronegative at baseline, and red is seropositive at baseline. As you can see, the vaccine and placebo curves, they separated right from the first dose. Efficacy was seen for the duration of the trial, and efficacy is seen both seronegatives and seropositives. If we focus only on hospitalized cases, we also have a similar graph. The difference at the end corresponds to nearly 90% vaccine efficacy, as we discussed. Now, moving into some exploratory analysis. So we looked into efficacy against individual serotypes by baseline serostatus, and in that analysis, for serotype 1 and 2, we saw similar vaccine efficacy regardless of baseline serostatus. However, for serotype 3, efficacy was demonstrated in baseline seropositives with 62% efficacy, whereas in seronegatives, efficacy wasn't demonstrated. We further looked into that data, as this is an important finding. One of the 6 cases in the placebo group required hospitalization versus 3 of the 20 cases in the vaccine group required hospitalization. So this is very small number of hospitalized cases to make any comparison, also to point out the 2:1 randomization ratio. So we'll continue to monitor this over the 3 years of additional follow-up that we have. For serotype 4, we could not make this assessment due to a small number of cases by serostatus. We have looked into efficacy in the time frame between the first and second doses, and during this time frame, we have an efficacy of 81% with a low bound confidence interval of 64%. And you can see in this slide, this efficacy is contributed by all 4 serotypes, cases in seronegative, seropositives, and both hospitalized and non-hospitalized cases. Now, moving into immunogenicity and safety. So the data is largely consistent with what we have presented previously with trials of this vaccine. We have a 99.5% tetravalent seropositivity in the seronegative group a month after the second dose. In terms of safety, we collected diary-reported event, unsolicited adverse event for a month after each dose, and serious adverse events, which continues for the duration of the trial. So we saw more injection site reactions, which was primarily driven by injection site pain, which is 27.7% in placebo versus 36.7% in vaccinees, is the all local reactions. And unsolicited adverse events were comparable in both vaccine and placebo groups. Serious adverse events rates were low and comparable, and we did not have any important safety findings. In systemic events from diary-reported adverse events, the rates of fever were comparable between vaccine and placebo. Typically, we do not see much rash with this vaccine, and very few subjects reported that. So to summarize the data which I presented, we met the primary endpoint with an overall efficacy of 80% at the end of part 1. At the end of part 2, which had additional 6 months of follow-up, when we assessed secondary endpoints, so we met most of the secondary endpoints, and we saw variable efficacy by serotype. We demonstrated efficacy in both seronegatives, seropositives. We have 90% efficacy against hospitalized dengue and 86% efficacy against dengue hemorrhagic fever. So we did not meet 2 endpoints, primarily due to lack of sufficient number of cases. one was a conclusive efficacy against serotype 4, and also efficacy against severe dengue using one of the approaches. In exploratory analysis, we saw similar efficacy against serotype 1 and 2, regardless of baseline serostatus. For serotype 3, efficacy was demonstrated in seropositives, but not in baseline seronegatives. And we could not make that assessment for serotype 4 due to lack of sufficient number of cases. In terms of safety, the vaccine was well tolerated, and no important safety risk has been identified. So after this time point from which I'm presenting data, the trial has additional 3 years of follow-up, which is ongoing, and we'll be presenting that data as it becomes available. Thank you for your attention, and I'll be happy to take any questions.
Questions?
I may have missed it, but did you look at efficacy differences by age at all?
Yes. So we have, thank you for asking that question. So we have also assessed efficacy by age. We have 3 age subgroups, 4 to 5, 6 to 11, and 12 to 16. So when we do the analysis, we see slightly lower efficacy in 4 to 5-year-olds. However, looking further into the data, so we see that that is confounded by the seronegative serotype 3 data. So if we take that out, we do not see any age effect.
Can you comment on the surveillance that you plan to do for the 3-year period, for the next 3-year?
Yeah. So for the next 3-year period, thank you for asking that. So for the next 3-year period, it has an active form of surveillance. So we call that modified active surveillance. It has weekly contacts, and it is also designed to detect both hospitalized and non-hospitalized cases.
I couldn't see the slides very well, but you showed seropositivity at multiple time points, including, I think, month 15 or so?
Yeah.
And the percentage is slightly lower, not still pretty high. Do you want to comment, or can you comment on the titers? How much decline did you see in antibody titers over that period?
Yeah, so typically, thank you for asking that. So typically we see a rapid rise after the first dose. And after the second dose, especially in the seronegative group, we do not see that much rise after the second dose, and which is also expected. It's a dose after 3 months. And after that, we tend to see some decline in titers. And after a year, they kind of stabilize. So in this presentation, I did not show the titers, but we have seen after month 4, it declines to month 9, and then month 9 to month 15, it tends to kind of plateau off. Yeah.
Is that consistent between serotypes, this decline?
So I would say the trend generally is similar. Typically, we see very high titers for serotype 2, which has the backbone. And then serotype 1, 3, and 4, they tend to comparatively lower compared to serotype 2. However, the trend of decline and plateau, I would say, would be similar.
Just a follow-up question on surveillance for the next 3 years. So you're seeing low efficacy in the seronegatives against serotype 3. I think you've also published that in the seronegatives, the dengue 2 titers are very high, but the titers against the other 3 serotypes are about a log lower in the seronegatives. So given the Sanofi experience as well, do you plan to do more enhanced surveillance for severe disease in the seronegative individuals who got your vaccine? Or is it just the routine surveillance, or maybe educating people about the potential, because we know the possibilities of unbalanced immunity in the seronegatives could be more severe disease?
Yes. Thank you for that question. So the finding on serotype 3 in seronegative is really an important finding. So currently, our surveillance for the whole duration of trial, and particularly for the 3 years that is now continuing, this is also has very intense surveillance, which includes weekly contacts and detection of both hospitalized and non-hospitalized cases. And so certainly we are monitoring this very closely, but in terms of surveillance, we do not plan to change it because we believe that we are detecting all cases of dengue.
So you're not going to do anything different with the seronegatives who got the vaccine. They're going to be treated the same as the seropositives.
Correct.
Follow-up period.
Yeah, so still it has, as I mentioned, it still has weekly contacts and detection of both hospitalized and non-hospitalized cases.
Maybe one brief question, if you could.
Sure. I wondered whether you have any data so far or plan to get it about severity of disease. So if somebody has clinical disease, the proportion that need hospitalization, whether the vaccine changed that, or if you have data about the duration of symptoms, whether that was different in the vaccine and the placebo cases.
Yeah, thank you for that question. So we have looked into that. If we consider the proportion which requires hospitalization in the vaccine group versus placebo group, so it will be higher in the placebo group compared to in the vaccine group that we have seen. Good. In terms of in terms of clinical symptomatology, so we also see some favorable symptomatology in the vaccine group compared to the placebo group, and we see that is primarily driven by the data in the seropositive groups. And so this is an important finding which we also continue to monitor. Yeah.
Thank you.
Thank you very much.
Thank you.
So the next presentation is by my co-chair,